Top Med Talk.
Hello, Top Med Talk listeners. Welcome to Top Med Talk here at Anesthesiology 2023 in San Francisco on the second morning of this wonderful meeting. I'm Mike Grocott, and I have with me my co-host and co-editor-in-chief as of yesterday.
That's right.
That's on you, not Desiree. So Desiree Chappell, how are you, Desiree?
Good, Mike, good.
Excellent. And also our guest co-host, Guy Ludbrook.
Wonderful to be here with great company, actually.
Excellent. So lots to discuss today, more great guests and conversations. And one of the wonderful things about the anesthesiology meeting is the great opportunity to catch up with old friends. So first up this morning, we have Ben Gibbison. Ben, great to have you with us this morning. What have been the highlights of the meeting for you?
Oh, the highlights of the meeting.
And you can include the climbing wall in that if you want.
No, I did that. Well, there's lots of nice things about being in San Francisco, like going for a run around the Marin Headlands and eating sourdough bread. But I went to a great session yesterday about I'm a cardiac anaesthetist and using cerebral saturation monitors, which I do, and we now have them standard on our machines, but people only use them in major aortic surgery. And actually, there was a great compelling case yesterday for using them on everyone. Because clearly on the bypass machine, pulse oximeters don't work because there's no pulse. And so actually having some marker of brain blood flow was a good thing. So I think...
You've said enough, you persuaded the folk back at home that you were actually doing some work. It wasn't...
Yeah. No, it wasn't. No. Going out for dinner.
Yeah. That's so funny. So personally, I did cardiac for 10 years and pretty much my entire career doing that, we were using cerebral oximetry on all cases, all cardiac cases. And I thought it was like everybody did that. But then I'm finding out that it's still yet 15 years later that is not standard practice.
No, and that didn't seem to be in the meeting. I mean, clearly, in the UK, we think, or certainly we think we're quite backwards and we don't do it. So we had one machine in our department which did 1,500 cardiac cases a year. Wow. Up until last year when we replaced all our anaesthetics machines, and now we've got it on them all, and we still don't use them all. And I think that's why I quite like this meeting. Really, is that last year I came and I started using BIS monitoring on everyone. I was convinced that using BIS monitoring was a good idea, having never used it on anybody before. And this year I'm going to, I think probably I will end up using cerebral SATs monitors on all my cardiac cases. I do by chance do a lot of sort of major aortic surgery, sort of arch replacements and stuff anyway. And we always use it for that. But actually, even for the straightforward cases, I think there's probably a compelling argument for it now.
Interesting.
So this is costing your hospital a fortune. If every year you come, you start doing something new.
Well, it is. But that's the thing about anaesthetics is it's relatively cheap and straightforward, as I think the study will go and talk about. We know the big things that save lives, oxygen fluids, antibiotics. Yeah. And everything else is sort of tinkering around the edges. And you have to be careful, I think, that you don't sort of just get carried along with the new latest tech gadget. But they're relatively cheap now, cerebral saturation.
But if you learn to use it, though, and you understand the functionality of it and how it can improve what you're doing and the monitoring, I mean, I know specifically about this. I mean, years and years you'd see something like, oh my gosh, what's going on when something would start to alarm. Didn't happen all the time, but every once in a while it did. And it's like, well, that actually picked up something. That was a big deal. Either, something was, you need to adjust something here or there or, whatever.
Yeah, well, I mean, I think it's difficult to show that a lot of this monitoring technology makes a difference to outcome.
Yeah.
And the one thing I would say that me using BIS monitoring, and I've now been using it for a year since October last year, is that it separates my blood pressure control from my anesthesia. And that's been the big thing, is that I now don't give a bolus of propofol to bring the blood pressure down before we go on bypass, because I watch the BIS crash and burst suppress someone for like 10, 15 minutes. So, but it's difficult to measure those outcomes in a trial, I think. So, but it's so some of the, you've got to be really careful that what you're doing has a modicum of evidence behind it.
I think the whole complex intervention, which is most of what we do. Evaluating is really difficult, as you might know from various shared projects. Now, Ben, we've got you along for a conversation to talk about a particular study, but before we do that, can you give us a little bit of background? You've given us some clues that you're a cardiac anaesthetist, but tell us a little bit about where you work, what your practice is, and you're a fairly active researcher as well, aren't you?
So I am an academic anaesthetist from Bristol in the UK, and my clinical work is cardiac anaesthesia and intensive care. But I actually work for the University of Bristol now. I swapped to be a full-time academic about 3 or 4 years ago. Trained in London, went to Australia, as Guy and I were talking about the other day. Sort of like
got that out of your system pretty quickly.
Decided I never ever wanted to go back to backcountry Australia again. And
you might want to clarify that.
I know,
we have a lot of Australian listeners.
Really.
You did love it there.
It was pretty backcountry.
Without naming the context, I think that's perfectly understandable.
Yeah.
It was not near any major city or the sea.
No. Yeah, it's high up on a hill. Yeah, so then returned to London, shipped out to Bristol, did my anaesthesia training. I realised that I didn't want to do general intensive care as a career, because that looked like bed management to me when you were a consultant. Whilst it was very exciting as a trainee, running around to all this stuff, it didn't look much fun as a consultant.
It's very complicated and very clever.
I was just going to say, sorry, Mike.
Totally. So I sort of decided I wanted to do some sort of research, and there was no research program running in Bristol. There's no academic person in Bristol. So I touted around. I actually went for several drinks with pubs with people, and I found a professor of medicine who's now a fellow of the Royal Society called Stafford Lightman, who does stuff about steroid research. And so we put together a project looking at perioperative hypothalamic pituitary adrenal axis control, and I got that funded via a project, and they happened to be again in a curry house in Glasgow. And I was struggling to get a fellowship because there was no sort of academic thing. There was a couple of MRC fellowships a year, and I couldn't get one. And I was sitting next to my colleagues who were cardiac anaesthetists, and they said, "Oh, well, look, we've got this fellow job going. No one's had it for 6 months, so we'd rather you come and did some work than no one doing any work. So we'll pay you a full-time salary. You can do your MD, and you just need to do the service provision part of the job." So I did that, and then I could get a project grant off the BHF, and then sort of carried on. And then I didn't think I'd be credible as a sort of academic anaesthetist, because I just didn't, and there was no support system there. So I went off to Papworth, did a fellowship, came back as a full-time NHS consultant, and things just sort of spiraled. If you're the only show in town, then people tended to come to you, and then it sort of picked up, and then
brilliant. And one thing led to another, and the GAP study came along. So tell us a little bit about the GAP study. What is the study? And I think you're going to be able to share the results for the first time.
That's great.
Med Talk exclusive.
You hear it here first.
Well, I presented it yesterday.
You'll hear it here second.
You'll hear it here second. So the GAP study is a study of the effectiveness and cost effectiveness of gabapentin in perioperative pain control, really.
And so this is not specific to cardiac. So
no, it's not specific to cardiac. It was funded. It was major surgery.
Okay.
So it was but 3 body cavity surgeries, so cardiac, thoracic, and abdominal surgery.
Oh, okay.
It took place in 7 NHS centres in the UK, placebo-controlled. It was originally powered. We were going to have 1,500 patients, 500 in each of those groups. It was powered to detect a difference of 12.5% in the length of stay in any one of those groups. And because of COVID and funding and things, actually, with the National Institute of Health Research, we needed a little extension to complete it, and the deal was that we basically dropped the power to 80% power. So we ended up recruiting, so 1,196 people randomised. Yeah. Half of them got gabapentin, half of them got placebo, but it was powered for length of stay. So actually, as a sort of composite of pain control, post-operative pulmonary complications, all of that was what the power was about, rather than sort of pain control, specific numerical rating score of pain or reduction of opiates, which we knew from the meta-analyses we'd done for it.
And I mean, this has been a big question, there was some literature that came out last year, really kind of not debunking, I guess that's the wrong word, but kind of questioning the use of gabapentin and how useful it really is, right?
Yeah, so that was what was interesting, was really the sort of, our study in fact showed what all the meta-analyses showed, which is, although it has statistical improvements in sort of pain control, it moved the numerical rating score from like 4 to 3 or something like that, or it moved the amount of opiates that in sort of a 24-hour period. It changed them from like 30 milligrams on the first day to 25 milligrams.
Yeah.
And it actually didn't affect the amount of time that patients stayed in hospital. It didn't affect anything else. It didn't affect their quality of life. Actually, the sort of long-term pain was worse in the gabapentin group, which sort of goes against the other stuff. And we followed these patients up. They got followed up daily in hospital, obviously, for safety and things like that. And then we followed them up at 4 weeks and 4 months afterwards.
You didn't see a difference?
We saw no difference in length of stay between either of those groups and in any group.
So the message for the practicing clinician, what do you take from that guy?
In my world, gabapentin was the universal panacea.
Yeah.
And often more for persistent pain. It's clean, it's great, it's not an opioid, so you can prescribe it, happy birthday. And then, of course, it didn't quite work out that way. And it's, really not necessarily that good for your head, depending on your dose. And that became a bit of a problem. And then some of the efficacy data, certainly persistent pain, weren't as strong as it might be, or weren't as consistent as it might be. So I'm kind of interested in terms of people's functioning on the trial. Did you look at that in terms of whether it did mess with your head, so to speak?
Yeah.
So in that we measured adverse events and serious adverse events, there was no difference between the two groups at all. One of the sort of limitations of the trial is that we had a relatively fixed dose, we had a very fixed dose of gabapentin. So patients got basically 600 milligrams of gabapentin as they were walking to the operating theatre or in the operating, in the anaesthetic room. And then 300 milligrams twice a day for 2 days afterwards. So it was a relatively fixed high dose. And that dose was based on a meta-analysis, a sort of dose-finding meta-analysis. And we think it was about right, because about half the centres went, oh my God, that's too high. And the other half went, it'll never work. It's way too low. You need to be using lower than that. So we thought we were in the ballpark. But what it meant is that, we don't know whether the people, whether clinical teams didn't randomise older people into the study because of that. So our sort of mean age was about 68, 69 for both groups. So we don't know the outcomes of sort of the older patients,
the more vulnerable.
Yeah.
But it raises the issue too about adjunctive drugs for pain relief. I mean, we're hearing about them here this week. We've seen a lot of work around that. We're seeing big trials of things like ketamine, which the data will be coming up before too long, one thinks. And then it's interesting in the regulatory world, which also I take off one hat and put another one on in terms of the regulatory world, is what do we see as important? I mean, you've spoken very much about that, say 1 point of pain score down, which is not an uncommon difference for all these adjunctives. How do you see that as kind of clinically relevant? I mean, just about anything will give you that. How do we kind of treat that scientifically? We might be able to make that significant. How do you see that in the sort of clinical context as important or not important?
There is sort of, clearly you can get into minimally clinically important differences, but and that's really in the realms of sort of 2 or 3 really, in a sort of numerical rating score of 0 to 10. So we didn't pass that. I'm a sort of simplist, and this is my particular view, is that actually why should you use 2 drugs to do it when you could use 1? And effectively, you can achieve the same outcome with 1 drug, then you should just use the 1 drug, because at least you know what's causing your problem then.
And so the one drug we often turn to for moderate or severe pain is opioids. How do you see kind of the future of opioids to a degree? I mean, are they all bad? I mean, in one view, you say, there's a group that said one should never give an opioid. And I've never managed to achieve that. So how do we kind of work that narrative forwards in terms of one camp, absolutely no opioids, one that they're fine? How can you see? Do you have a sense of where opioids are going to be in 5 years, 10 years?
I think it's going to be constantly debated. Well, you didn't ask me, but that's what I think.
No. Well, I think it's going to be constantly debated. I think that it is very difficult to do major surgery without any opiates at all. And, I say this as a sort of sign-up member for cardiac anaesthesia community who gives big doses of fentanyl every day, and it's really difficult. I think there needs to be more rational prescribing. Clearly, there's a difference between opiate. There's a big problem. One of the things I've been quite surprised about in San Francisco is the number of people on opiates on the streets. Just walking here this morning, I must have stepped over several people who are on opiates. And so actually bringing opiates into an environment where they can be used safely in hospital And I think part of that thing about opiates is it's been driven by the out of hospital, sort of all opiates are bad, and clearly the misappropriation of prescribing opiates rather than, people have taken cancer guidelines effectively for end of life care and applied them to people who are in their 40s with back pain. And so it's not necessarily that opiates are bad. It's about you have to have a framework for using them that's safe. And in hospital, in the perioperative environment, is fine. Our cardiac patients, so, these people that have had a saw taken to their chest, go home 5 days later and they don't go home with any opiates at all.
Yeah.
It's vanishingly rare because we just don't prescribe them opiates and they're not in pain.
I think there's a real contrast because we have a number of conversations on Top Med Talk with folks from the US where the major concerns are about opioid prescription going home.
Yeah,
often 30 days of opioid prescription and respiratory depression due to opioids in hospital, which are problems which I think in the UK we really don't see very much.
I'm sorry to interrupt. It is a major problem. And I mean, you said here in San Francisco, it's every major city you will see people on the streets, struggling with opioid use. And I'm from Kentucky. It was the epicenter of some of the original issues. And so I think what's happened is that, and we see this in so many things, the pendulum is swinging back and forth to varying ends. And so, a lot with our surgical patients, I think the movement towards reducing or more judicious use of opioids and working with our surgical colleagues through their perioperative stay and post-op journey when they're home, saying, we did this, we're being stewards as much as we can with team anesthesia. Let's all work collaboratively together to all do that. Because we would have patients that would go home with like a cardiac patient that would clearly not really need them, lots of opioids, and they get, a 30-day prescription of, 60, 80 pills, something like that. And that, that was normal. I think some of that's being pulled back, but then we see a lot of these people on the street. Part of the problem is that there's been so much crackdown on not letting people have opioids, with the people that have been chronic pain patients that have been on opioids, not abusing them, now have been taken away. And so they have to, will go to street drugs and things like that to try and supplement.
But do you think the driver, sorry, I'm going to ask a question now.
Yeah,
do you think the driver for people using, or for, US physicians giving drugs to go home with is the cost thing, is that they feel they're providing a service and that they're being paid for? Because one of the things in the UK is I think we tend to give people what they need rather than what they want.
Yeah. I don't think it's, I mean, it may be some of that. And I mean, I'm not a surgeon. I'm not a prescriber myself. I think part of it is, the push to have no pain after surgery.
Yeah. Pain is the fifth vital sign.
Pain is the fifth vital sign story. And that patients expect no pain. Like a 0 out of 10, well, they think they should be 0. And if they're not, they give more pain medicine. So prescribers and people who are, reading the orders to give will say, oh, they must be having some pain. I must give some pain control. Because as a nurse, if you were at the bedside, you were actually penalized if someone came out with a high pain score. So what are you going to do? You're going to give them narcotics to keep them quiet, essentially sedate them. And so I think that was part of it. I think part of it too was that because patients didn't want to have any pain, and we're sending patients home more quickly out of the hospital. They're not staying in hospital as long after their surgery. So then they're going to have a little bit more pain. So then they're calling the surgeon at 3 a.m. saying, I'm having so much pain. I need more pain medicine, because we weren't giving a lot of pain medicine. So I think it's been, it's been a ramp up, and now things are pulling back. And, I think surgeons didn't want a lot of calls. There's a lot. I mean, it's a time thing too.
Ben, thank you very much. So just the take home that I get is don't bother.
I think for major surgery, major body cavity surgery, it makes very little difference at all to anything. I think, again, one of the limitations of the study is we didn't look at major non-body cavity surgery. So we didn't look at major joint replacement, things like that. We didn't look at replacing ambulatory surgery where they might try opioid free. But certainly for this big stuff, I wouldn't bother.
That's so interesting. I meant to ask this earlier. Our enhanced recovery protocols, for years have all included that as a multimodal pain regimen. I think why you were saying that. And we have seen a tendency for people to start pulling back on those. Did you happen to look at patients that were already on gabapentin
No. So they were excluded from the study.
Yeah. So if you have someone coming in on it,
I think you probably just have to carry on.
Yeah.
But it's a great message. I mean, negative trials are incredibly helpful. And so, that's a really good message.
Yeah, that's great. Well, great. Congratulations.
Thank you very much.
Fantastic work. And
well, it's not just me. I mean, there's a massive team.
For sure.
It took me a whole night to put together the list of people for the report we had to send to the NIHR. So there's an enormous number of people that do this.
Shout out to all your friends that have helped out.
Great. Ben, thank you very much for sharing the results. Only second to hear the results in the world.
You heard it here second.
We really appreciate you taking the time and coming along today.
No problem.
Thank you, everyone, for listening to Top Med Talk, making the world healthier through the power of conversation. And thanks for following us on social media. You can find us at topmedtalk.com, on our YouTube channel, on X, formerly known as Twitter, for those who are keeping up, and LinkedIn. We will be back with another great conversation. So see you then.
Cheers,
Bye-bye.
everybody.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.